Hi everyone. So let's go ahead and take a look at section 5 of chapter 20 here. And what we're going to be taking a look at, this is one of the key things because that's where we left off in the last video, is we were talking about local blood flow and the amount of blood that goes to the capillaries and capillary beds and how it can be controlled and regulated. But one of the factors that local blood flow depended on was total blood flow. And we're going to be taking a look later on at how total blood flow is regulated. But in this section, we're going to be taking a look at how blood pressure and resistance is going to influence total blood flow. So that's what we're going to be taking a look at. We're going to go through blood pressure, the different types of blood pressure and the vasculature. Then we're going to be taking a look at resistance and the different types of resistance that we have. And then we're going to put it all together and take a look at how those are going to influence total blood flow. And how they're all going to be related. So let's go ahead and talk about how they're related before we talk about this nice little blood pressure here. So flow is going to be equivalent to the change in pressure over resistance. So you might be thinking, okay, what is this change in pressure? We definitely have a blood pressure gradient if you take a look at what's happening in the vasculature. So just looking at blood pressure and the definition, it's the force per unit area of blood against the vessel wall. So anytime you see pressure, it's going to have to do with a force. We looked at hydrostatic pressure, and that was going to be the force a fluid exerts against a structure. And here, blood pressure is going to be, of course, very similar to hydrostatic pressure in the fact that you are working with a fluid, which is blood, and how it is going to be a force against a structure, which is the vessel wall. So if you think about it, we do have a pressure gradient. Look at that, a pressure gradient. It's going to go through the entire vasculature. So you are going to start here with the highest pressure in the aorta and look at what happens as it goes across the vasculature and it gets to zero all the way down into the veins. So the pressure is going to be highest in the arteries and it's going to be lowest in the veins. So that's what really propels and drives blood through the vessels is going to be this blood pressure gradient from one end to the other. So that's what we're looking at here is the difference between two pressures. So let's go ahead and first take a look at this pressure, which is going to be in the artery, so the arterial blood pressure. And then we'll take a look at what's going on in the capillaries, and then we're going to take a look at what's happening in the veins after that. So let's start with arterial blood pressure. So remember that blood flows, if you remember back in the cardiac cycle, how it goes through this whole contraction, relaxation phase, right? And so because of that, it causes these pulses that are going on with blood flow in the arteries. Look at it. It's kind of going through, looking at the pulses that are going through, the blood flow that's going through. So there's basically two types of pressures that we are going to be looking at here in the arterial blood pressure. The main ones that we're going to be looking at. Systolic pressure. So systolic pressure is going to be the pressure in the arteries during ventricular systole. So don't get systole and systolic pressure confused. So yes, they are related because systolic pressure is going to depend on systole. Remember, systole is going to be the what's going on in the chamber whenever it's contracting at the heart, and the ventricle specifically. And that is going to influence systolic pressure, which means what's happening here in the arteries whenever the heart is contracting. So this systolic pressure is going to be the highest pressure generated in the arteries, and it's going to be where your arteries are maximally stretched. Look at it down here. So it's going to go through this whole stretch, and normal systolic pressure is going to be 120 millimeters of mercury. So, of course, with the cardiac cycle, you had diastole as well. And that's where we get diastolic pressure. Diastolic pressure is going to be the pressure in the arteries during relaxation of the heart. So, again, don't get these two confused, although they are going to influence diastole in the heart is going to influence diastolic pressure in the arteries. So, these systolic and diastolic pressures occur in the arteries. Diastole, systole is going to occur in the heart. So diastolic pressure is going to be the lowest pressure generated in the arteries, as you can see. And that's what happens once once an artery stretches, it needs to recoil. And that's where the recoil is going to be here, is with this diastolic pressure. And you can see it right here, that recoil. It is going to be average 80 millimeters of mercury. You know, sometimes those numbers change, but that's going to be average 120 over 80. So we can use diastolic pressure and systolic pressure to kind of give us an idea of what's going on in the heart and how that's going to affect different things like blood flow and health and other things like that. Let's take a look at how, since we did talk about this whole stretch, recoil, how it's going to be pulsative, that is going to bring us to this pulse point that we are going to have throughout the body, which is going to, of course, be related to pulse. Pulse is just going to be this throbbing of the arterial wall. Again, stretch, relax, and it's going to determine heartbeat. So usually it's going to be more forceful, like with high blood pressure. If you just recently exercised, you can have a little bit more of a forceful pulse. But if you go in to take someone's pulse in various points of the body, these pulse points that we're going to take a look at, and you do not feel a pulse, then that is going to indicate that flow to that body part is lacking. So you have these various pulse points in the body, and it's usually these nice superficial blood vessels, these arteries that can be compressed against a solid structure like a bone. One of the most common places whenever you go into the doctor when they take pulse is going to be the radial artery, because of course you can go in and that artery can be compressed up against the bone right there, and it allows the healthcare worker to go in and feel the pulse that way. But as you can see, lots of different pulse points along the body that doctors can use, especially if they go in to see how blood flow is in an area like down here in the feet, especially, you know, looking for circulation for diabetics and things like that. So those are the different pulse points of the body. So let's take a look at how we can use systolic and diastolic pressures to find other pressures in the body. So there's a pulse pressure. Pulse pressure is going to be the pressure in arteries by heart contraction. That is really just going in and taking the systolic and finding the difference between systolic and diastolic. So usually that's at about 40 millimeters of mercury. And it reflects how elastic the arteries are, how good it's going in and stretching and relaxing and stretching and recoiling, I guess I should say. And remember that elasticity definitely declines with age, so pulse pressure can be used to look for that. Let's take a look now at how we can use pulse pressure to find something called mean arterial pressure. And this is just the average of blood pressure across the entire cardiac cycle. So this is a really great way to go in and look at blood flow and specifically look at the amount of perfusion in the entire vasculature. So that's found by taking diastolic pressure and taking a third of the pulse pressure. So if diastolic is usually 80, and then you take your pulse pressure, we just found our pulse pressure, and divide it by 3, then we should get 93 millimeters of mercury. I say about because there is a decimal point that we're not going to worry about. So really anything between 70 to 110 millimeters of mercury is going to be a adequate perfusion. Anything less than 60 is going in and indicating that there is insufficient blood flow throughout the entire circuit. And it makes sense, right? Because what you're going in and looking at is these two different pressures that are coming from or stemming from the heart. So it's going in and saying, hey, something's going on with the heart, or it could be something along the lines of the blood vessels. So it's a really great kind of indicator as far as blood flow. All right, so that is arterial blood pressure. So let's go ahead and move down to the vessels that are going to have a little bit less of pressure, and that is going to be our capillaries. Capillaries, by the time we get here, pulse pressure is zero. There's no longer a fluctuation between systolic and diastolic, so the flow and the pressure here are nice and smooth. So we need to have pressure high enough. So, because remember that here in the capillaries, we are exchanging fluids, we're filtering out fluid, and then we're reabsorbing fluid. And that depended on hydrostatic pressure. So that's why we need it high enough to exchange substances, but we need it to be low enough not to go in and damage any of the vessels. So remember, this is what we talked about back in the capillary exchange video, how at the arterial end it's roughly 37, and then as it goes across the capillary bed, it goes to about 17. So that's a nice little rounded number that you can remember. And again, the capillaries rely on this blood pressure to be this range so it can go in and exchange substances. So now let's go to the very end of our pressure gradient, and that's going to be veins. So the venous network is going to have the lowest pressure. If you think about it, it is the furthest away from the pumping heart, right? Because the aorta is going to be right there attached to the left ventricle that is going to push out blood into the systemic circuit. And then this is going to be pretty much furthest away. So by the time it gets into the venules, it's at about 20 millimeters of mercury. But when it gets to the right atrium, the pressure is almost zero. So it's so low. There's no pulse either. And remember that one thing that cardiac output relies on is venous return. That stroke volume relies on venous return, which is going to be that movement of blood from the capillaries back to the heart. And you're thinking, okay, well, pressure is really low here. It's not pulsative. How in the world are we going to be able to get the blood back from the, especially like from your legs, all the way back up to the heart if there's no pressure? So that's why we have other mechanisms that are going to help return blood to the heart. The veins are going to rely on something called the skeletal muscle pump, and it's also going to rely on the respiratory pump. So let's go ahead and take a look at these two. So this is a great picture showing the skeletal muscle pump. And really what it's talking about is how whenever you have contracted muscles, remember if your muscles aren't contracting, then they are going to kind of be a little bit more thin, I guess you can say. Well, let me go over here and draw what a relaxed muscle would look like on this side. Not very good, not just like that. Compared to a contracted muscle. Remember when a muscle contracts, it kind of bows out a little bit, not a little bit, but it can bow out quite a bit off to the side. So that's what it's relying on. It's going in and relying on whenever you contract your muscle and it gets fatter in the middle, it goes in and squeezes on those blood vessels right here. Specifically squeezing on these veins. And whenever it does that, it's acting like kind of a tube of toothpaste where you're squeezing it, and hopefully it's going to go up to the heart. And look, you also have another mechanism that's making sure that venous return occurs, and it's going to be these valves. The valves are open here so we can get to the heart, but look what's happening over here. They're closed down here to make sure that backflow does not occur. So that's the benefit of your skeletal muscle pump. It's going to help kind of squeeze on those veins to help push that blood up to the heart. That's why it's really important if you ever have to stand for a long period of time, then just make sure you kind of move your legs a little bit, because anytime that you have any kind of leg movement, you're contracting your muscles, and it's going to help squeeze and help facilitate that whole return to the heart. That's why if people do stand at attention for a long period of time, or they lock their knees, you know that term, they might faint. And one reason why, it's because of the fact that blood will kind of start to pool down in the lower limbs, and there goes venous return because you're not contracting these muscles. So venous return decreases, which means that decreases cardiac output, and you're not getting the blood that you need to all of the organs, especially your brain, which can cause you to pass out. So as soon as, of course, you're in that horizontal position from passing out, blood goes back to, of course, blood is going to eventually get to the brain because of that horizontal position, and that is going to allow you to regain consciousness. So it's always really important to make sure that you move, just contract your muscles just a little bit anytime you have to stand for long periods of time without walking around. And we'll talk about, of course, what happens whenever you sit for long periods of time and how that can be detrimental as well. Now let's take a look at what's happening here with the respiratory pump, and how exhalation and inhalation is going to work. We'll talk a little bit more about the pressure differences and volume changes later on when we get to the respiratory system. But if we just kind of take a look and see what happens during inhalation, or you can use inspiration as well, it increases blood flow into the thoracic vein. So what happens is the intra-abdominal pressure increases, and that kind of squeezes on or compresses the blood vessels down here in the abdominal pelvic cavity. But that's going to help increase blood flow into these thoracic veins. And then whenever we exhale, that is going to help move the blood that we just squeezed into the thoracic veins, and it's going to help increase it into the heart. And also it's going to help increase it into the abdominal veins, so it can go through the whole kind of circuit that way. So this whole inspiration, expiration is going to help facilitate blood movement as well. So let's take a look at some issues with veins, just like we a long time ago, we looked at issues with arteries. Maybe this should be moved up a little bit, but let's take a look at varicose veins. So varicose veins can occur from if you stand for a long period of time, from obesity, pregnancy. Look at all of these things that can result from varicose veins. So what happens in these conditions, with pregnancy, you have this larger blood volume, extended standing. What eventually happens is it can inhibit venous return. So look at the veins. This is a normal vein, but this is a varicose vein, and it's going to cause the veins to get dilated, tortuous, which is basically how they're going to be all kind of in this twisted shape. But also the valves are going to get weak because of it as well. So especially if you have a dilated vein, then that means that the valves can't completely close because of that. So what the issue you have is you have this kind of pooling in the blood vessels, and so it can look like this superficially. So this is very common in the lower limbs, and I think now they can do laser surgery to remove varicose veins. Whenever varicose veins occur in the anorectal region, that's whenever they are going to result in hemorrhoids. And this is usually because of some kind of increased abdominal pressure from straining, or pregnancy can cause it as well. So here's varicose veins. Let's take a look at what happens whenever you are sitting or standing for a long period of time. And this can cause something called deep vein thrombosis. So we talked about thrombosis back in the hemostasis, in the blood chapter with hemostasis, and with clotting. But this deep vein thrombosis is going to be where you have a thrombus in the vein. And again, it's usually because of immobility. So maybe an individual in a wheelchair or in bed rest for a long period of time, or even if you're on an airplane, a long maybe overseas airplane, or if you're a truck driver, anything like that are going to be risk factors, and heart disease. So as you can see, this is most commonly going to happen in the calf. So as you can see, you have your valve there, but you are going to have this kind of this blood clot that is going to start to form. And it's mainly because you have blood pooling because you're not moving like you need to. So eventually this could go in, and if the blood clot breaks free, or if any piece of the blood clot breaks free, remember that's going to be termed an embolus. And if it gets to the lungs, and that can become a pulmonary embolus, and if it's lodged in the lungs, and can cause death. So some of the symptoms, signs and symptoms of deep vein thrombosis is going to be fever, tenderness, and redness, rapid heartbeat pain, swelling in the area, and things like that. So if you do have to sit for a long period of time, like an overseas flight, or if you're a truck driver, it's always really important to make sure that you get up and walk around. You know, you've got to make sure that you don't have immobility in the legs, issues like that, because you could have an increased chance of clotting. So let's take a look and kind of sum up blood pressure. And again, the blood pressure gradient in the systemic circuit is mainly going to be this difference between what you have in the arteries. There's that map that we talked about, the mean arterial pressure. And then remember that the blood pressure that you have in the vena cava is going to be 0. So the blood pressure gradient across the systemic circuit is going to be 93 millimeters of mercury. So really this whole pressure gradient is going to be the driving force that's going to move blood through the vasculature. And so we'll talk about how this increase in gradient is going to help increase total blood flow. But if you have a decrease in this gradient, then you can have a decrease in blood flow. So blood pressure is going to be affected by things like cardiac output. We're also going to talk about how resistance can affect blood pressure, which we're about to talk about. But also blood volume is going to affect blood pressure. If you think about how I relate it kind of like with a tire, if you have an increased amount or increased volume in your tire, you have an increase in pressure. And if you have a decreased volume of air in your tire, then you have a decrease in pressure. And that's exactly what's happening here in the vessels. Is if you have a increase in blood volume, then you are going to have an increase in pressure, and vice versa. So we'll take a look at that later on. So the next video you guys are going to watch is going to be over resistance. So until next time.